Our next speaker, as Dr. Hayes alluded to, is Dr. Anjana Kundu, and she will be speaking about chronic pain management. She is a professor of anesthesiology and pediatrics at Dayton Children's Hospital. She's board certified in pediatric anesthesiology and pain medicine and integrative medicine. She's the immediate past president of the Society for Pediatric Pain Medicine and the president of, or the founder of Proactive Pain Solutions, and has served on the governor's cabinet on opioid action team in Ohio. And she's an excellent speaker as well.
Thank you, Rita. No. I do need the chair. I mean, I thought, you know, at least I'll have some company with Stephen, but I will stand on it. Here's the thing. If I stand here, I can't see my own slides, so this is definitely a conundrum. Can you guys hear me? All right, so I'll just lean really heavily in here. All right, thank you, Rita, for the, I'm good. I'm good. I'll just stand on my tippy toes the whole time. That's all good. Good exercise. All right. So who's heard this? My whatever body part you want to insert hurts. What can you do to help me? All right, a few of you. All right, great. Me too. So here's the thing. Dr. Hayes gave a really good overview of whatever little literature we have for treatment of pediatric pain. And Dr. Brown's coming next. She'll tell you about all the biobehavioral therapies. So my job's done, so I'm gonna be going now. Thank you. I'm like, that's all I got for you. All right. Since Rita invited me, maybe I'll stay for a few minutes, and since I'm gonna get exercise for my calves, that'll be good too. So I'll tell you a little story. So you might be wondering, since I don't really have actually substance to talk about, I'll talk about bird feeders, right? So here's a bird feeder in my backyard that my husband put up a while ago. And this happens to be our second bird feeder, actually, not the first one. The first one met this. This was the demise of our first one. And that's from a gunshot. I know I'm at AAP, and how dare I even speak that word, right? Well, this is basically to give you a little preface for what can happen when we act before we have all the information, or use some common sense. So our bird feeder was really close to our raised bed and to the tree, as you can see in the background, and the squirrels were getting to it. And they were also then getting into our raised bed because now there was more incentive and they were destroying my vegetable garden. And that just, my husband said, oh, I'll take care of it. Just to tell you, my husband's a really nice guy and not violent and really responsive with guns, just a disclaimer. But he had a little, glorified BB gun, said, I'll take care of the squirrels. Sure enough, he did take care of the squirrel, but so did he take care of the bird feeder that was useless to everything else, right? So my point here is, without understanding the underlying issue, I think when we act, or when we don't use logic, we can get into a situation that we don't want. And that's kind of where my spiel about pediatric chronic pain is. We may not have all the information that we want to have, but we certainly have common sense. And we have some information to go by, some from acute pain, some from adult pain. And then obviously some, for sure, within pediatric pain, even if it's not pharmacological information of great quality, but we have some things to go by, and that's what we'll discuss. So my goal here today is going to be to give you an idea of what is different about chronic pain, just so that we understand, so that we can use our logic in treating chronic pain when we do that. Just in order to understand that, I'll go over the nociceptive targets and basically targets for pain control, because that's what's going to help us use our common sense, and factors that make pain a subjective experience, which is going to be very, very brief, because that's what Dr. Brown is going to talk to you all about next. And few treatment modalities, but I'm going to kind of skip over most of them because Dr. Hayes has done a really good job of briefing you on them, just touching upon what that means for chronic pain. And just a little bit about what we can look forward to, what's on the horizon. All right, so disclosure, I'm the founder of Proactive Pain Solutions that Dr. Agrawal just said. It's an online consultation and education company, and so that's that. And I will be discussing off-label use of medications for chronic pain because that's kind of what we got. All right, so let's get to know chronic pain. Dr. Hayes already told you it's a sensory and emotional experience associated with actual or potential tissue damage. So there doesn't have to be an evidence of tissue damage for us to assume that the child has chronic pain. And that's not Dr. Hayes' definition, it was the IASP, as he also said. So interestingly enough, obviously we're talking about sensory, which is nociceptive, and emotional, which is biobehavioral, which is what Dr. Brown is going to talk to you mostly about. So again, I feel like I'm just passing time with you guys. Quick epidemiology. Despite the fact that we have little information, we do know that the incidence is actually climbing for chronic pain. We have data that 1 in 3 school-age children, so between 6 to 17 years of age, that are reporting some kind of chronic pain or recurrent pain. And numbers go between 28 to 84%, depending upon what the study used as, and 84 is more in terms of chronic, life-limiting illnesses. There is a significant amount of functional disability, definitely impact on mood and because of mood, both, sleep, and social functioning as well. So those are some of the hallmarks of chronic pain that we get to see that we don't see in acute pain as much, even though we see some emotional distress, but we definitely see a lot more of impact as well as a role of these factors in chronic pain. And up to 12% of these children, so somewhere between 5 to 12% are the numbers, have severe disability where they are completely disabled. They're not leaving home. They may not even be ambulating. They are not going to school. They are not interacting. They're not doing basically anything that a child should be doing. Higher incidence of chronic pain and mental health diagnosis into adulthood is very well established. So if a child has chronic pain, they grow up to be adults with chronic pain and mental health diseases, or diagnosis, I should say. And I'm sorry, I skimmed over. Economic burden is up to the basically numbers of about $20 billion. So this will tell you a little bit about why this, is a big issue, because pain is not just the nociceptive, as we've already established that, but nociception does form the basis of where pain experience comes from. But basically pain comprises of nociception and then the experience of pain, which is influenced by emotional factors, psychological factors, and mood, and all that good stuff, as well as then the suffering that comes from it. As a lot of you would have heard, right? Pain is inevitable and suffering is optional, and there's a lot of truth to that, and I'm going to drop that right on to Dr. Brown to unpack that. And then, of course, from all those come the pain behaviors, and that forms the package of chronic pain, really. So let's go over quickly a real quick primer on neuroanatomy. I know you didn't think you're going to be in anatomy class, right? So let me see if I can actually figure out, how do I? All right, so noxious injury happens, so quickly here. And what happens is once this injury happens, there's a release of inflammatory substances, neuropeptides, cytokines, prostaglandins. That's what it does is changes the basically how the membranes here speak to the injury that's happening and to the upwards channels, which is spinal cord and the brain, which we're going to get to in a second. So when the inflammatory substances are released here, the cytokines and such, the prostaglandins and such, what they do is they change the membrane basically the permeability of the membranes of these nerve endings, which is what Dr. Hayes was talking about, the A, delta, and C fibers and their subtypes that carry different kinds of pain information. And this process, when this injury stimulates these and there's a flow of ion channels across these and causes an action potential which forms an impulse, that's called transduction. So that's the initiation of pain impulse. That goes into the first order, this is carried by the first order neurons, goes into the dorsal root ganglion and dorsal horn of the spinal cord. And that's where it just kind of says, okay, I'm done with my information now, somebody else, you're it. So that's a relay, right? So then the second order neuron, it speaks to the second order neuron here and takes the information upwards. So what's happening, in order for these two to speak, they don't talk directly. It's not like I'm going to dump information on you and here's the baton you take. There's actually a space that is filled here, and that's filled with excitatory substances that are released, all in response to this noxious stimulus that happens. And then this crosses over to the other side. And next it goes to through the spinal cord on the opposite side, through the midbrain into the thalamus. And that's up here. And that's where it's relayed and goes to the third order neuron. And the third order neuron is the one. So this process from the second order, basically from the start of the first order neuron to all the way up to the somatosensory cortex, which is up here, which is where the ultimate information happens, is this is basically a transmission. And so the reason I'm talking about these and some of these things that are occurring at each level are basically your targets for pain control. All right, so, well, I don't know how to go back. There, sorry. All right, so what happens here, it goes to the thalamus, which is sort of basically a deep level of your cerebral cortex, which is where it's going to relay the information into the ventroposterior lateral nucleus, which basically gives it a name that I'm feeling pain. So that's the nociceptive sensation. And then it stays close to the other areas of like the amygdala and that limbic system. They're influencing, and that's where your fear and worry and concerns come about. And all that information then packaged together goes up to the somatosensory cortex, and it tells us this is pain in the right hand, big thumb, and plus I'm like scared to death about it, right? Because I've had this experience before. So all that stuff happens. So that's basically your perception of pain. But right as it's sending that information up to the somatosensory cortex, the midbrain also initiates a second set of signals, which is the descending. So ascending pathways take the information up, and the descending pathways are the ones that modulate pain. So ultimately, when somebody experiences pain, is a sum total of what goes up and what comes down. So now let's quickly talk about what comes down. So the first order neuron for the descending pathway comes down from, again, thalamus, down in an area called periaqueductal gray, in the midbrain, and then which plays a really big role, as well as the medulla, nucleus magnus raphe, the other area. So all those come down, and that's where it brings the inhibitory pathways down back into the dorsal horn of the spinal cord, and then that's where the second order neuron for the descending pathway works. But here, again, there are substances that with neuropeptides that will facilitate this information, and those are the inhibitory. So that's where you've got your GABA, you've got your 5-HT, serotonin, and adrenergic receptors. And that's what we want more of. Those are kind of like you're facilitating your endogenous opioid analgesia. So I promise I'm almost done. The other thing that, also happens when these second-order neurons are relaying this information in the spinal cord is that they also activate the interneuron, which is the third kind of neuron, which is sort of this guy, green guy here. And so if you look at this is a really, really important area of the spinal cord. So what's happening is this is a second-order neuron that's releasing inhibitory things. It's stimulating the interneuron, which basically releases the endogenous opioids, enkephalins, and those will then inhibit this information exchange between the ascending first-order and second-order neuron. So all these places that I just mentioned are basically our targets for pain control. All right. So if you look at, so first order, basically we're going to look at are the peripheral ones because they're inflammatory soup that gets released there, so anti-inflammatory work there because it disrupts the membrane, so the membrane stabilizer, which will be your anticonvulsants and even some of your tricycline antidepressants, as well as some of the newer targets that we're going to talk about. Then some of the counter-stimulants, because what kind of fibers get stimulated here decides how much information is going to go up. And this is transient receptor potentials. Again, that's just what happens at the membrane here. So those are brand new that are being investigated right now. The next obviously level is your anti-inflammatories, opioid that also have some higher targets, which would be steroids because they specifically work as anti-inflammatories in the dorsal horn. And then we have the opioids, which are throughout as we saw in the spinal cord as well as throughout the central nervous system. And the capsaicin, which works to decrease the substance P. All right. So basically, your peripheral targets are your anti-inflammatories. You've got your voltage-gated ion channels, which are in the membrane, which are going to be your anti-epileptics, as we talked about, and your TRP agonists, and the steroids along the pathways, as well as what works to activate different fibers are counter-irritation or counter-stimulation, so which will be TENS unit, massage, acupuncture, etc. So here are basically your different areas that opioids work, right from central as well as to almost to the peripheral areas. But then you've got your alpha agonists like the dexmedetomidine and clonidine that Dr. Hayes mentioned. They're also throughout the central nervous system as well as a little bit peripherally as well, right? So central targets would be the endogenous opioids that we can stimulate by counter-irritation, massage, acupuncture, as well as TENS unit, as well as the exogenous opioids, which is what we do opioid therapy, and we'll talk about what the role of that is in chronic pain, alpha-2 agonists, and steroids and antidepressants, and as well as the NMDA antagonists, ketamines. The NMDA receptors are basically at this on the second-order neuron is where and that's what goes haywire in neuropathic pain. That's why we need the NMDA antagonists like ketamine and dextromethorphan. All right. And of course, you can go as far as actually stimulating the spinal cord and the deep brain stimulation as well, because they will induce all these pathways. So what makes pain subjective? Again, I won't talk too much about it because Dr. Brown is going to. It is more important, Hippocrates says that we should know the patient. This is a subjective experience of pain, so we should know what's coming into all this experience. So what are the influences? We've got biological influence, the biggest one we just talked about. So there could be biological differences in how each one's nociceptive process goes, as well as you've got the temperament of the person, their coping, their mood. You've got social factors playing into his school, family, peers, all of that, as well as cultural, what kind of biases they may have. And even us as healthcare professionals can influence pain experience from patients, whether we believe them, what we make of the information they give us. So what can you do to help? So multimodal as well as multidisciplinary treatment. So multimodal, many things, of course, and multidisciplinary, many practitioners with different sets of skills, because as we saw, there are so many different targets for pain control. So obviously non-pharmacological would be those multiple disciplines we talked about, and pharmacological treatments. I will quickly go over them, even though I'm running out of time. Rita will give me 2 minutes grace. All right, so I'm going to skip over the psychology, but we'll talk about the physical interventions. So chronic pain results from failure of modulation. So that's what really is happening. That's the difference. So it's not a process of ascending pathway, it's the descending pathway that fails. Therefore, anything we could do to support the modulation is what we need to do, and physical interventions are the most effective ones we can use. Treatment focus should be functional restoration as opposed to treatment of the intensity of pain. So because we've got massive functional disabilities associated with chronic pain. And we know that all these physical interventions stimulate the endogenous opiate pathway, as well as it augments neuroplasticity. So it allows the brain to reformulate how it's sending, receiving, or modulating the information. And if obviously doesn't let further loss happen. So there are a lot of studies out of Boston Children's as well as Stanford that there are only a limited number of programs that do provide intensive level of physical rehabilitation, which mostly is for children that have functional disabilities. And multiple studies have shown that there's a higher level of satisfaction, both for patients and families. There's improved function, pain symptoms, emotional functioning, reduced medication use, as well as an interest in engagement for their therapy. So they actually accept it and want it more. There is, for a headache program, there were a number of days that were decreased, and there was, but unfortunately, like I said, there are very limited resources. There are only 11 programs throughout the country that can offer that. Acupuncture, we talked about where it acts. Endogenous opioid analgesia is stimulated, as well as it changes how pain is perceived and interpreted. It's good for, there's most of the evidence is from adults, but we also see in back pain, osteoarthritis, but it needs training. All right, I'm gonna skim over massage, but it's a great modality. You must, again, explore that as an option. In terms of the opiates, my bad. Anticonvulsants are basically membrane stabilizers. And they will obviously provide some of the modulation that we were looking for. They definitely are the ones that will change how the receptors are responding, how the information is carried out. Therefore, neuropathic pain, they have a significant role in that, and they reduce opioid analgesia. And this is all there are results from adult studies, but not in pediatrics, we don't have any randomized controlled trials yet. Here are some of the anticonvulsants that can be used. All right, in terms of alpha agonists, centrally acting, they're weak analgesics by themselves, but great for multimodal analgesia. Consider muscle relaxants for any musculoskeletal pain as an adjuvant. You must also you can also consider topical local anesthetics or regional blocks, but you'll have to refer to a specialist for that. In terms of use for opioids, for chronic pain, there is extremely limited data to suggest that chronic pain responds to opioids. As a matter of fact, we end up seeing opioid-induced hyperalgesia for these patients. And cannabinoids are being discussed, but they're also very weak. Opioids only seen in adults, neuropathic pain and pain related with MS and spasticity. For pediatric, it has no role whatsoever. New targets are, like I said, they're being investigated, are the calcitonin gene-related peptide receptor antagonist, just got approved for both for abortive as well as preventive therapy. And in summary, what I would say is chronic pain is a multidimensional experience. It's a biopsychosocial phenomena. So think of it that way when you're assessing. Make sure you know the degree of dysfunction. Make sure you employ multimodal analgesia early on, because we know that they grow up to be adults with pain. And pharmacological therapies by themselves won't be giving you much results. We need to have the other interventions like the physical therapy, rehabilitation, as well as what Dr. Brown is about to talk to you about. Thank you so much.